Thank you for having me with you in this very important meeting. That's very interesting also. I'm going to speak about ACS syndromes and COVID-19 with case-based discussion. I'm starting with some data about COVID and the predictors in hospital death in COVID patients. As you can see, coronary artery disease, congestive heart failure, and arrhythmias are making having a significant role. And if you look on what happened in Italy in last June, you can see that most people died from COVID. They have been associated with two or three or more comorbidities. So comorbidity is another important factor in these patients. Now about the involvement of cardiovascular involvement in COVID-19. Actually, we have more than one mechanism acting in order to, particularly for provoking acute coronary syndromes. One starting from inflammation, then microvessel endothelial dysfunction, and as well as coronary artery, epicardial coronary artery endothelial dysfunction, and finally the cytokine storm, which is instabilize the plaque, and this all these mechanisms are participating to produce acute coronary syndrome in these patients. And actually, it is not only acute coronary syndromes. We might have non-ischemic injury of myocardium, direct injury of myocardium. And again, comorbidities are still there. And finally, the clinical manifestation can vary from cardiogenic shock to heart failure, myocarditis, acute coronary syndromes, arrhythmias, pericardial effusion, and so many clinical manifestations. If we look on acute coronary syndromes, we can see it's not always associated with obstructive coronary disease. Sometimes it also can be associated with normal coronary arteries, and this is mostly due in patients with stress or cytokine dysregulation and endothelial dysfunction as well. So let's come to our case. This case was done in April 2020. We had at that time severe local epidemic situation with total lockdown, separate COVID section in our hospital that was mainly pneumology department. But at that time, we had some available beds in ICU in order to be able for emergency to accept people also for emergency. This patient had 60 years old, male. He had hypertension, obesity. He was also a cigarette smoker and dyslipidemia. So at least 3 comorbidities are there. Onset of chest pain 20 minutes back, before arriving in hospital, with persisting chest pain and dyspnea. And this was electrocardiogram on arrival. As you can see, a typical anterior wall STEMI. Blood pressure was 110, heart rate was 82, and oxygen saturation 190, 95. There was an increase in troponin. Now, at that time, we adopted very fast screening for COVID risk in this kind of patient, and mainly by interrogation of the patient or parent or the person who accompanied the patient at that time, in order to have some idea about whether the risk to have COVID is high or low. And even in low COVID risk, total protection was recommended at that time. And after the procedure, the cath lab should be sanified, and the patient should be isolated isolated and tested for COVID. If positive, will be transferred to the dedicated COVID section. Otherwise, will stay in our department. The management was generally general strategy highly depends on severity of local epidemic situation, and at that time we have really severe epidemic, but in the meantime we're considering that PCI, primary PCI in STEMI, is the gold standard treatment, and we tried to offer this optimal approach for patient whenever we were able. However, in some circumstances, thrombolysis can be good an alternative, particularly in those with exceed the revascularization time window, or those who need transportation from other hospitals without PCI capability, and of course with the patient with acute heart failure or severely symptomatic for COVID patient also was also avoided to bring to the cath lab. Of course, in these patients, optimized medical treatment should be taken as well. Delay, of course, what should be taken in consideration in COVID in COVID pandemic severe situation, and this mainly due for the screening, the cath lab staff, also protective gear, the limited emergency medical services due to some sick staff or systemic overload, bed overloads, or all these things, and patient fear in contracting an infection from the hospital, so they were not so happy to come to the hospital. And we know that the impact of the treatment delay will increase mortality in ST segment elevation, whether it is associated with shock or not associated with shock, or with out of hospital cardiac arrest or not. And you can see that mortality is highly affected by the delay. And this also happened in our country in that period with severe pandemic. As you can see, total ischemic time was significantly increased, total door to balloon time was significantly increased, and total mortality, in hospital mortality, was significantly increased as well. Looking on the statements and recommendation coming from scientific societies, we can see again, even during the COVID pandemic, primary angioplasty, a standard care for STEMI patient, capable hospital, when it could be provided in timely manner, and fibrinolysis-based strategy may be entertained at non-PCA capable referral hospital, or in specific situation where angioplasty cannot be done. The same situation also for the European positions. That means we have in timely possible angioplasty will be the first option in all patients coming into the hospital with ST elevation, myocardial infarction. Fibrinolysis will be in the other, that where angioplasty cannot be done. Of course, we should remember the contraindication for fibrinolysis therapy every time we are practicing that. Beside of this, of course, protection is very important, particularly if you are operating in pandemic situation. That means active pandemic situation or peak symptomic situation, and the protection level is also important accordingly to the severity of pandemic in the regional, in the local area. Coming from level 1 protection to level 3, the full protection level 3, and this of course is related to what you are doing and in which situation you are doing. But again, a good protection should be taken every time you are doing something which might be with somebody who might have or probably can have some the infection. Now back to our patient. This was angiography, just total occlusion of LAD at proximal level, and right coronary artery, you can see here, was totally occluded as well. But again, if you look on what we have done, we have done the manual thromboaspiration. This was the angio after thrombus aspiration, and the huge amount of thrombus was aspirated from right coronary artery, and this is the final result, just simple stenting, and the procedure finished really in very short time. So after the procedure, because of the severe pandemic situation at that time, patient was isolated, COVID test was performed, which resulted negative, and patient was discharged after 4 days event-free. Now, we have another second scenario now at the present time. In May 2021, local situation, very low number of new COVID cases. We have 80% of local population is already vaccinated. Lockdown is quite completely removed. And now this another case of ACS with young man, cigarette smoking, dyslipidemia, hypertension, and familiarity for cat. He was vaccinated 2 months back with Pfizer vaccine. Rapid COVID test in emergency room was done and was negative. So this patient have been treated with the standard, our standard, even before COVID pandemic. But with still with the precaution, the protection of patient and cath lab operators are still at level 2 protection, personal protection. This was a first clinical manifestation. Persisting chest pain started 40 minutes back. Blood pressure was 105. Pulse was there was tachycardia, and saturation, oxygen saturation was 94%, which is borderline. Troponin was increased a bit. This was the angio. As you can see, severe disease on left main, proximal LAD, proximal also circ, and marginal, and total occlusion of right coronary artery. Because of the persisting chest pain, we decided to go ahead with angioplasty. And again, this is schematically what is summarizing what we have done before. That means during the severe pandemic is like what I have mentioned for STEMI before. Now, this is also the guidelines, the management of patient with non-STEMI, and you see that very high risk patient as our patient, immediate invasive strategy is recommended. For all other categories, test is recommended before, and then if positive, to transfer to COVID. If not, to test to go for invasive early in high risk, intermediate, and low risk to non-invasive testing, and then decide whether to go ahead or not. Now, coming back again to this patient, after this is the culprit was left main and circumflex, and you can see here, I'll show you what happened after we have just wired the vessels. You can see here the patient starting having ST elevation infralateral wall with persistent chest pain, blood pressure dropped to 75, and heart rate was increased. We decided to proceed for PCI, but implanting before the intra-aortic balloon pumping and intubation of the patient because he was really severely compromised. Then after this, we have completed the procedure, as you can see here. Soon after procedure, hemodynamic stabilization, on ACG regression of ST elevation, blood pressure came back to 110, and so intra-aortic balloon kept to 1 for 12 hours later and then removed, and intubation removed on the following day. That means 12 hours later, patient out of intensive care unit on second day with complete recovery, discharged on the 5th day, and the complete revascularization with the CTO for procedure for RCA was completed 3 weeks following the index procedure. So coming to my take-home messages, I'll say that COVID-19 infection can directly affect the heart. ACS is one of these manifestations. The invasive approach in acute coronary syndrome, especially for ST elevation myocardial infarction, is the gold standard approach and should continue to be offered to patients with acute coronary syndrome in PCI-capable hospitals. In the peak infection emergency should be guaranteed for high-risk patients, while alternative solution can be adopted for patients who are not suitable for invasive approach, out of perfusion time window, low-risk patients, or elective procedures. Precautions are never enough. A quick approach to assess the risk of COVID every time you are doing having a patient in a cath lab. Person protection also for entire staff of cath lab, for the patient, as well as the post-procedure sanitation can make it possible to continue to offer the invasive approach even in areas with high infection rate. Further essential keys, the capacities of local health services, the reorganization of hospitals based on the severity of pandemic and the viability of beds, and dedicated cath lab and personal protection equipments. Of course, the statements consensus from scientific societies can help in decision making regarding ACS patient, since being always updated in relation to the evolution of pandemic and the exchange of experiences and knowledge that have been acquired. And I think this kind of meeting is also very useful in order to learn about what is going on and to learn how to proceed and to acquire more and more experience regarding this severe pandemic. Thank you very much for your attention.
And what we have, thank you, Imad, for sharing your experience of cardiovascular disease and COVID. 1.5 months back, I came across this case, which I'd be discussing. And we are getting a lot of patients post-COVID, otherwise normal. They present within a month with acute coronary syndrome with STEMI. We have a lot of cases coming up. So today I'll be discussing one case. This is locked-in syndrome post-primary PCI in a COVID-19 patient earlier case. So this is a 67-year-old lady. I've done PCI, elective PCI to LAD and POVA to diagnose 12 years back. She's on regular follow-up. She has no other risk factors. Her ejection fraction was normal. She was on aspirin and high dose of rosuvastatin. Nearly 1.5 months back, she came with a ischemic chest pain of 4 hours durations. Since last 4 months, she was complaining of fever, lethargy, and shortness of breath. And at ER, her SpO2 was 90%. And that period of time, it was a peak of COVID in our country. So this was a suspected case of COVID. Echo screening in the emergency showed ejection fraction of 35%, mild MR, and hypokinetic LAD territory. I don't have a previous ECG here. What you can see in ECG is Q waves in anti-release. There's ST elevation in V1 to V4, 1 AVL, and reciprocal ST depression in inferior release. So this is a case of STEMI, 4-hour chest pain, a suspected COVID positive patient. So our protocol is any patient with STEMI, we do primary PCI, of course, with the protectors. So we took her to the cath lab. What we can see here is a coronary artery. There's some moderate lesions in the made our sales not very significant. And this was a left, we can see a tight lesion in the mid part of the circumflex. We can see here, it's a selective into circumflex. We see the lesion in the proximal LAD, which are totally occluded. So this was a radial of this. Bar was passed and pre-dilated with 2.5 into 12 balloon. And what you can see is that there was a short event, so I deeply engaged the catheter into LAD. And this was again post pre-dilated with the balloons. And this is a picture here. Some lesions in this is another view. So decided to put a long DS in this lady. Put a long DS, 3 into 30. Put the wire in the diagonal. Diagonal was at least moderate size. And then post-dilatation was done with 3 mm balloon in high pressure dilatation around 16 to 18 atmosphere, and serial dilatation was done. This is a serial dilatations. And since there were some lesions in the ostium of diagonal, so I was thinking whether to go for 2 stent or 1 stent. So dilated that ostium with 2.5 into 8 mm balloon and did a kissing balloon in this patient. This is a picture, some lesions distal to diagonal. It was 5 mm to 12 balloon in 18 atmosphere. And the part was done in proximally with the 3.5 balloon. This was a 3 mm stent. So this is a picture here. And this is a final picture. There's some disease and I thought I would not be chest pain. So she became chest pain free and transfer this patient to coronary care units. Suddenly in the evening, she complained of sudden onset of left lower limb weakness, and there was slurring of the speech. This was 4 hours after procedure in the evening. So did a CT scan in this patient. This is a CT scan of the patient. And we did cannot see any infarction or hemorrhage in this patient. So this was patient was treated with the guideline-directed medical therapy with aspirin, ticagrelor, ACI, beta blockers, and high dose of rosuvastatin and some mineralocorticoid receptor antagonists. In the late night, I get a call saying this patient has now progressed. Her right lower limb has become weak, and then both upper limbs have become weakened, and there's a she can move her eyes. So this was a case of pseudocoma state. This was a post-primary PCR after 12 hours. And then again, repeated the CT scans. It consult with the radiologist, said not much changes what we have seen from previously. What was concerned to me was whether there was any bleeding or some ischemia. So I could not, they said this is not much change in previous. So now early in the morning, I did consult with a neurologist. Since this lady had quadriplegia, first thing the neurologist said is that this could be a case of bacillary artery infarct. So we did a CT angiogram for cerebral vessels, and there was no stenosis in the major vessels while with the CT coronary angiograms. So what is important of circulation in pons is majority of blood supply from the bacillary arteries. There's some supply from superior cerebral artery and some from anterior inferior cerebral artery, but the major supply is from the bacillary artery. So my hospital is around 180 bedded dedicated cardiac hospital. We do not have any neurologist. So neurologic consultation was done. And the neurologist says we might have some small lesions. So patient was advised for MRI, and this patient was sent to the hospital for. And this is a picture of MRI lady. Can somebody mute? Somebody mute down, please. This is a MRI of this lady. And MRI, there's a infarct. Can somebody mute, please?
Dr. Arun, do you hear me? Sound? Dr. Arun, do you hear me? Probably Dr. Arun, please, I will come back again. Please unmute yourself. Please unmute.
Okay, sorry.
Arun, share your screen.
Please unmute yourself.
Arun,
Hello.
Arun, unmute yourself.
Yeah.
Okay, sure.
Okay, sorry. So what was the report is because CT scan did not show anything in two CT scans, one in the evening and one night, and we did a CT cerebral angiogram, did not show anything because MRI is quite sensitive.
Sir, sorry to interrupt you, sir. Please share your screen, sir.
Oh, it's not shared?
No, sir. Kindly share your screen.
Okay, just a second. Just a second. Is it coming now?
Yes.
Okay, sorry. So did MRI in this lady. The MRI says there's a bilateral Pontine infarct. There's a chronic lacunar infarct in left basal ganglia and right middle temporal lobe. So MRI is quite sensitive in finding out the lesions, especially in the small vessels. And we did CT scan twice, it missed, and we did also CT coronary angiogram and did not show anything else. So she was in guideline-directed medical therapy, aspirin, ticagrelor, beta blocker, ACI, aldosterone antagonist. She had quadriplegia, and my hospital is 180-bedded dedicated cardiac hospital, and we do not have any facilities for neurologists. So we sent this patient to referred other patient to hospital. During hospital stay, her saturation dropped. She developed ARDS. She was intubated, and she expired after 5 days of post-MI. So what is the incidence of stroke in cath labs? The incidence of strokes in cath labs in diagnostic procedure is within 36 hours is 0.01%. For therapeutic procedures, is 0.1 to 0.4%. This occurs more in case of valve interventions and atrial fibrillations. And however, the asymptomatic embolism can be reported. It has been reported up to 2 to 20% cases in various studies. The stroke has high mortalities. The 30-day mortality reported is 19% for ischemic stroke and 50% for a hemorrhagic stroke. So when you find any patients with Pontine infarctions, the American Stroke Association's synonym is FAST: facial dropping, arm weakness, and slurred speech. The most important is time is brain. We all know that any patients with acute ischemic stroke, 4.5 hours is very important. And the presentation of Pontine infarction may be different. It may present simply as impaired breathing or loss of consciousness. In our patients, it present with the lock-in syndrome. Entire body was paralyzed except for eyes, and some may even present with visual or hearing disturbances, changes in sensations, weakness in the lower limb, and swallowing or speech difficulties depending on the lesions in bones. So what are the risk factors involved for ischemic strokes in pons? It is postulated that the leading risk factors are hypertension and diabetes. This hypertension and diabetes lead to lipohyalinosis of small peripheral arteries of the pons, and that leads to chronic ischemia and infarctions. And there are different postulations like atherosclerotic plaque in large arteries or vertebral or bacillary arteries cause infarction in pons. Other risk factors postulated are smoking, hypercholesteremia, history of ischemic stroke, hypercoagulable states, and vasculitis. However, the risk factors which increase the risk of infarctions in pons are still unclear. So the management strategy is, if any patient's getting stroke, acute stroke, we have a choice of IV thrombolysis or intraarterial thrombolysis or big vessels mechanical thrombectomy. If the patient symptom onset is less than 4.5 hours, then thrombolysis is the treatment of choice. I reviewed the literatures in the midline and Google's. So I found one patient in the Netherlands Heart Journal, which has given this journal says acute pontine infarction after Perkin's coronary interventions are rare but devastating complications. This is the only reported publications which I could find. And there's also one literature saying that if the patient has COVID, the locked-in syndrome can occur in one patient, in a young patient. And this is one literature saying that COVID can present with a locked-in syndrome. So what is the mechanisms? It could be either cytokine activations or platelet activations or direct endothelial involvement or fibrinolytic suppressions in a patient's the mechanism of COVID-19 associated coagulopathy and thrombus formation, which Professor Imad has described in detail. So what is lock-in syndrome? This is a pseudocoma. The patient is aware and conscious, cannot move or communicate verbally due to complete paralysis of nearly all voluntary muscles in the body. There's a vertical eye movement and blinking. Patient is able to communicate with eye movements only. So this lady has locked-in syndrome due to pontine infarctions. Her COVID we did a COVID test in the evening and it turned out to be COVID-19 positive, and that period of time was quite pandemic in our country. And this is a post-primary PCI to LAD presenting with very late stent thrombosis 12 years after PCI to LAD. So the other causes of locked-in syndromes like poisoning, especially with the crake bites or neurotoxic venoms, if there's any cause due to brainstem strokes, central pontine myelination, secondary to excessive rapid correction of hyponatremia, stroke or hemorrhage in the basilar artery, traumatic brain injury, or lesion in the brain stem. So the conclusion is pontine infarction after PCI is very rare. Benefit of IV thrombolysis will alteplase, and mechanical thrombectomy is time dependent, so time is brain. To the best of our knowledge, we could get only one case of COVID-19 associated locked-in syndrome and one case of acute pontine infarction post-PCI. This has been reported in journals as Midline and Google search. This is, we believe, a single case of COVID-19 patient post-primary PCI presenting with acute pontine infarction and locked-in syndrome. So what is the cause? Is this COVID responsible for stent thrombosis or pontine infarctions, or whether it is a problem related with the procedures or iatrogenic procedure related Pontine infarctions. As I've already mentioned that this Pontine vessels occur mostly from basilar artery, superior inferior cellular artery, and isolated Pontine infarction post-primary PCI is very, very rare. So I would be happy to get answer from panelists what went wrong in these patients. Thank you very much. Thank you, IPDI, and thank you all panelists.
Thank you very much, and Assalamualaikum. The topic that I'm speaking on is vaccination in cardiac patients, risks and benefit. Now, as of yesterday, this is data published by Singapore Ministry of Health. The world is looking at 180 million people die with COVID, and mortality number, we are looking at about nearly 3.8 million. In Singapore, we have 35 mortality out of about 62,000 patients affected, and that constitutes about 0.05% mortality. My topic will cover three areas. I'm going to talk briefly about COVID and heart disease, types and efficacy of vaccine, and the safety of vaccine in heart patients. I think this was pretty much covered by Dr. Imad Shaman. He mentioned about the potential mechanism of heart injury in COVID-19 infection, which can include direct viral myocardial injury and myocarditis, heart attack causing from a thrombotic process, stress cardiomyopathy, and systemic hyperinflammatory response. We know that if you have existing cardiovascular disease, your mortality is 11% higher than people who've got no other comorbidity. And we also know that in the 1/3 of patients with COVID-19 patients, they manifest evidence of sustained heart muscle injury in the form of troponin elevations. And the higher the troponin elevations, lower the survival rate. So higher rate of abnormal heart rhythm, as well as higher rate of heart failure. And what's worse is that if you have existing cardiovascular disease and you have troponin that is elevated, you find that your mortality approaches that of 80%. This is from the Chinese study. So this is something that all heart patients should really be concerned with. So what are the types and efficacy of vaccines? So what is vaccinations first? Now, vaccination is a simple, safe, and effective way of protecting people against harmful diseases, as we all know. So it utilizes one's natural defense to build the resistance to specific infections when exposed and makes your immune system stronger. So vaccines train your immune system to create antibody just as it does when it's exposed to a disease. We know that from a history of our human battle against pandemic, the only way to beat a pandemic, and oftentimes the most sure way, most powerful weapon, is really through the introduction of vaccines. So we have a history such as smallpox as well as poliomyelitis, where vaccines truly prove its worth against such pandemic. There are basically three main approaches to making vaccine. You can use the whole virus as a whole, or virus or bacterium as a whole, or you can use a part of the virus or the bacteria to trigger immune systems, or you can use a genetic material within the virus or bacteria to produce the vaccine. Now, if you decide to use a whole micro approach, then we have the inactivated vaccine, where you basically denature the vaccine, or a live attenuated vaccine, or using a viral vector vaccine mechanism. So when you use an inactivated vaccine in a whole microbe approach, you basically try to inactivate or kill the virus using chemicals, heat, or radiation disease. And this requires special laboratory facilities. All this actually requires virus to be grown in the laboratory before it can be produced. So the examples of inactivated vaccines will be our flu, polio vaccines, as well as the Sinovac vaccines, which is being used now against COVID-19 infection. Then we also have the live attenuated vaccine. These are living virus, but they are weakened, which will include MMR vaccine, chickenpox, and shingles. But they are not suitable for people with compromised immune system. Finally, we have the viral vector vaccine, where you take a little bit of the viral specific subparts, inject it into a harmless virus, which can be injected into a human, commonly adenovirus. And some of these common vaccines, example will be the Ebola vaccine. Now, the other ways of making vaccine is to take a specific part of the vaccines. And in this case, we can use the spike protein, for example, of the COVID-19 virus to produce. But oftentimes the subunits can be in the form of a protein or a sugar, and we have many such examples of vaccines using parts such as whooping cough and tetanus, and even your hepatitis B virus vaccine. And finally, a genetic material can be used to produce a vaccine. This nucleic acid vaccine uses a section of the genetic material that produces the instruction for the specific protein, but not the whole entire microbe. And so the famous one will, of course, be the DNA and the RNA vaccines that we are now commonly using. The difference between DNA and the messenger RNA or mRNA vaccines is that DNA vaccine actually use a re-engineered virus to be introduced into the immune cells. But the RNA that was introduced in these latest vaccines do not go into the nucleus of the cell. It simply needs to be delivered into the more accessible outer region of the cells in the cytoplasms, where they take over the entire protein machinery production to produce the spike proteins to stimulate the immune system. Now, in the COVID-19 messenger RNA vaccines, we know that mRNA vaccine, mRNA itself is very unstable. So it has to be coated in a bilayer lipid and introduced into the muscle cells. Once the lipid layer facilitates the entry of the vaccine into the cells, the mRNA is released and take over the production of the protein and produce this spike protein, which is then released into the rest of the body to stimulate the immune systems. The mRNA vaccine by itself, the breakdowns within 48 hours, so there's nothing left after 2 days. And the mRNA can never get into the nucleus to alter the genome of the cells. So we know that the current science know that there's a lot of misconceptions, but certainly we know that mRNA does not enter into the cell's nucleus to alter the human chromosome. And actually, it is more than a decade technology has been used in treatment of cancer in patients, and also in some of the vaccines, such as the HIV, rabies, as well as influenza virus. Now, this is a lady that produces the pioneer mRNA technology. She was dismissed from a professorship in University of Pennsylvania way back in the 1995 because of her work on the mRNA, which was not commercially productive at that time. But she stayed on and sold the technology to Dr. Sahin and Dr. Turasi, who started this BioNTech company, and then together they are now millionaires producing the mRNA vaccines. Then we also have Stéphane Bancel from Moderna, who took 2 days to create the RNA sequence that can produce the spike protein, and in just slightly over a month, shipped the first bulk of vials to the National Institute of Health, USA, to begin the early trials of mRNA vaccine. So you can see that the mRNA vaccine development has shortened the whole period of productions from that of a clinical, from development to that of bedside clinical applications. From an average of 8 years for most of the vaccine, now we are talking about a matter of months where you can actually mass produce this mRNA vaccines. So when we talk about vaccine, we always talk about vaccine effectiveness. The vaccine efficacy numbers refers to how well they lower a person's chance of getting sick with COVID-19. So when Pfizer BioNTech vaccine tells you that it is 95% efficacious, it just means that for vaccinated people, it was 95% efficacious in protecting people from getting a symptomatic COVID-19 infection. It does not mean that 95% of people vaccinated won't get COVID-19 and 5% will. So similarly, Moderna's vaccine is 94% efficacious. So it was 94% efficacious in protecting people from COVID-19 infection. In fact, if you look at the FDA standard of efficacy for any vaccine approval, you just need to be 50% efficacious in protecting a person from the disease, and that will be approved. WHO requires a 60% efficacy for approval. So when you look at Pfizer, BioNTech, and Moderna mRNA vaccine, both has got very high overall efficacy. But to me, what is even more important is that it actually protects people from getting severe disease. 92% in BioNTech and 100% in Moderna, lower hospitalizations in the region of about 90%. And very importantly, nobody dies of a COVID-19 infection once they are vaccinated with an mRNA vaccine. And that it becomes a real game changer in this battle against a COVID-19 pandemic. when you look at the efficacy compared throughout or with all the current vaccines commonly used, Sinovac has an efficacy of 65 to 90%, depending on the studies. You look at J&J about 66% and AstraZeneca about 70% efficacious. We know that the Pfizer vaccine can give an early production 12 days after a first dose, and this is a study coming from Singapore. But collectively, when you look at some of the international data, particularly from that of Israel and United States, we can clearly see with mass vaccination, there has been a significant reduction in the number of hospitalizations for COVID-19 patients, as well as the number of deaths. In fact, the number of people infected with COVID-19 in Israel following 60% of herd immunity acquired from mass vaccination has now dropped by 30 times. And the number of people who actually, the number of people who catch the infection dropped by 30 times, and number of people who require hospitalization dropped by 10-fold and above. So no question here that the mRNA vaccine reduces the infection risk, reduces the severity of the disease, and there are some studies to suggest that it actually reduces the transmission of the virus, even against the new variant of concern, the Delta virus. So what about the safety of vaccine, which everybody is worried about? This is a Singapore data from the administration of nearly 3 million doses of vaccines already. The commonest side effects for this mRNA vaccine is actually rash of about 28%, angioedema about 14%, urticaria 13.7%, 5.6% of people who do develop fever after a vaccine dose. But the presence of side effects are generally good because it at least tells you that your immune system is responding to the vaccine. But even if you don't get any side effects, it doesn't mean that your vaccine is not working and that your immune system is not activated. But what we do know from the use of this mRNA vaccine, particularly a Pfizer type, is that the second dose oftentimes evoke a higher incidence of side effects compared to the first dose. 74.8% has got pain and 50% has got fatigue and so on and so forth. But most of this and fever is much higher with the second dose compared to the first dose of 25% versus 7.4%. But I have to say that most of the side effects are generally mild and self-limiting and can be treated with very simple analgesic therapy. In fact, what we are most concerned with is the anaphylaxis following mRNA vaccine. As of January 2021, the quoted global anaphylactic risk for COVID-19 vaccine from Pfizer is 5 per million, the Moderna is 2.8 million. But when you have more and more people receiving this vaccines, the difference appears to be narrowing with time. What is of interest to us as cardiologists is that this is our first patients who developed post-vaccine myocarditis. A 28-year-old male who developed fever and chest pain the second day after receiving his second dose of COVID-19 mRNA vaccine. And you can see from the ECG, there's global ST segment elevations with PR depressions in the lead 2. On top of that, on the MRI scan, we can see that there was subepicardial, lateral as well as apical late gadolinium enhancement consistent with myocarditis. And when we first submitted this case to a international journal, we got scolded by the editor for generating unnecessary alarm and it might turn people away from vaccine. But since after that, there were more and more reports coming from states and everywhere reporting the incidence of myocarditis after COVID-19 vaccination. So there is a definite association here, but the causal link has yet to be fully established. So I would say that at this point in time, it should be considered as a very mild as well as rare complications of myocarditis or myopericarditis after COVID-19 infection. And there's no the overall risk benefit of administering this vaccine continues to be favorable. So this is Singapore National Development and Vaccination Plan. So we started the vaccination program back in December 2020, and hopefully by August this year, which is about 2 months from now, we should achieve 2/3 of populations having full vaccination. And according to our Prime Minister, vaccine is the key to living in this COVID-19 world. And hopefully by the time we hit the 2/3 of vaccinations, the border will be open because we think that there will be sufficient protections of the populations to open the country again. So this is myself taking the first the 2 doses of vaccine of Pfizer way back in February. And after receiving, we'll all get this badge here to say that thank you for making the difference and keeping all of us safe. Now, the thing about the vaccination here is that there are a lot of vaccine hesitant, as we all know, and vaccination, the decision to vaccinate or not is really a very personal one. And I can tell you that this is a lot of vaccine hesitants are driven by misinformation about the side effect of the vaccine. And so mass education of the population is critical. So you can see many of such advertisements and public education messages being rolled out in Singapore throughout all the media. In fact, now everybody can take mRNA vaccine unless you are allergic to the first dose of mRNA vaccine. So even in cancer patients, even in pregnant women, even in lactating women, breastfeeding women, all patients with allergy to any sort of food or drugs are eligible to take a mRNA vaccine. And so there are very few conditions in which mRNA vaccines are not allowed. You have to receive the first dose and develop allergy before you will be rejected for receiving this mRNA vaccine. Specifically from Singapore Cardiac Society, we are encouraging the population, particularly patients with pre-existing cardiovascular disease, to go for vaccination because they carry the highest risk of severe complications from the COVID-19 infection. And even if you don't want to vaccinate, you'll find that there will be increasing discriminations against people who are non-vaccinated. So if you are vaccinated, you will be given more liberty. But you find that there are many companies like Qantas who will refuse to take any passengers who are not vaccinated. And that in New Zealand, if you're a custom worker, you don't want to take vaccine, you'll be sacked from your job. So the Singapore strategy against COVID-19 pandemic is about testing, it's about tracing and isolation, and vaccinations being the most important strategy against this COVID-19 pandemic. And it's because of this 3 strategy that Singapore is highlighted as one of the best country in the fight against COVID-19 in the Time magazine, and is rated the 4th safest place to live during this pandemic. With that, thank you very much for your attention, and I'd like to pay tribute to all my colleagues who went outside their duties to combat this COVID-19 infection.
Thank you, sir. Thank you, sir. I think really a masterclass presentation. All of the 3 presentations is excellent, sir. Our next session is very much exciting for the young colleagues. They're the free paper presentation and competitive session. Please stay with us. Now I'm requesting Professor Afzalur Rahman. He is the former director of IPDI, chairman BIT, and governor ACC Bangladesh chapter. Professor Afzalur Rahman, sir, please.
Yes, please. This is really, thanks IPD for inviting me. This is a great session. And there was 3 speakers, one is Imad Sawan, my close friend from Italy. That is great presentation. And another is Tan Huisim. I think so. He's not a cardiologist only. Now he's a non-cardiologist also, because he elaborately demonstrated all the types of vaccine. So I have learned a lot of things from him. And another is the Arun Muskie. Arun Muskie's case is always something's new. He always sees the complication and series of complication. His complication never be 1, 2, 3, and ultimately patient either survive or die. That's fine. Unfortunately, in our country, we have a very hardship of the vaccine. We have only the AstraZeneca vaccine, but it is less number. So we are not protected, and less number. Government is trying to give the vaccine for all of the peoples, but it takes time. In our country, regarding the primary PCI, we are really facing a lot of the difficulties. Most of the hospital in our country, we are depending on the thrombolytic because tentative place. But sometimes patient pushes us that we need a primary PCI, even in tertiary hospitals. So we have to do that. But our protection is not like the type 2 or level 2 or level 3, because it has to be protected for all, not for me, my technician, my nurses, and what the patient has protected. That we cannot do that. That's really challenging in our country. So we are really still dependent mainly on the thrombolytic, that's tentative place. And we go for pharmacoinvasive mostly after within 6 to 12 or 24 hours, and when the COVID test is negative. And if the COVID test is positive and patient is stable, then we ship the patient to the COVID positive arena, and we discharge the patient and come back again when the COVID is negative. These are the strategies we are following. It is more or less Chinese protocol. Chinese, they are following the protocol initially. Though the recommendation is that primary PCI is the gold standard, but due to the lack of resources and lack of protections and lack of coverage, we are doing the most of the cases are the pharmacoinvasive, that is thrombolytic, followed by the invasive strategy that are standard protocol. But still, we are doing the primary PCI in some of the cases. That's fine. And regarding the vaccination, what I understand that they give the protection 95% and mortality is 0. That is very encouraging to us. And because nobody dies when the patient is vaccinated, that's good news. And if somebody is vaccinated and infected, there is no mortality. But I don't know about the AstraZeneca vaccines is giving the protection like that. That I'm not sure. But AstraZeneca and Moderna vaccination give the 100% mortality benefit. That's great. I think so. And it is very difficult to understand the Warren-Muskie's cases. That is the syndrome. Actually, it is due to COVID or other causes. It is very difficult to say. So thank you very much. It is really an honor for me to join here.
Thank you, sir. Thank you. Talk because we are running short of time. Please shorten your comments. Professor Shundip Mishra here. He's raising his hand. Professor Shundip Mishra, please comments.
Yeah, thank you. I just have a short question for Dr. Tang. Because the mRNA vaccines like Moderna or Pfizer are against a spike protein. So how can a spike protein cause myocarditis? I mean, I don't understand the mechanism.
So this is something that we still don't know. I personally think it is part of this reactogenic side effect that we are seeing this mRNA vaccines causing. So many patients develop fever, lethargy, and so forth. Something about this sort of reactogenic side effect that is very commonly observed with mRNA vaccine is behind this myocarditis. So a lot still need to be understood, but I think this is probably the case.
Okay. So maybe it is because of the things that are added adjuvants along with the mRNA. So that's one. So other thing I wanted to share with you is that there are a lot of Latin American countries where despite vaccination, a lot of people are getting infected and they are actually seeing a rise in cases.
Oh, আজকে একটু ব্যস্ত আছি যে
Sorry, the question.
I was talking about vaccine escape seen in some Latin American countries where they're seeing another wave despite achieving a very good vaccination. So I'm not very sure if really this is the situation with all the vaccines. There is some saying that okay, some Chinese vaccines may not be that effective, and because they got Chinese vaccination, maybe they are seeing another wave of or another epidemic wave. But I'm not sure. But the point is that just vaccination is not enough. One has to make this very clear that despite vaccination, people require the COVID appropriate behavior. And so far as Astra vaccination is concerned, I know of a case who received 2 full doses of vaccination. 15 days later, doctor himself, and this person is a very famous person, I don't want to name him, he died. So you can't say that just mere vaccination is 100% protective against death. So I'm just saying, and I don't know which, maybe some vaccines are protective, I don't know. We still need some data on that.
Yeah,
but I know of a case. Yeah,
that's a good point. So when we talk about vaccine efficacy, we are not saying that you will not develop breakthrough infection. We are saying that you have a 95% chance of not developing a symptomatic COVID infection. So having given 3 million doses in Singapore now, we have 120 patients who have been vaccinated and have developed a breakthrough infection. However, these 120 of them develop either no symptoms or very mild symptoms and were just picked up on surveillance. So this is very useful to us because now I know I have just converted a potentially deadly disease which carries a mortality of 2% to one that is very similar to a seasonal flu, perhaps of less than 0.1%. If I can achieve massive herd immunity, I think that is fantastic news. So I think if we can convert a somewhat deadly disease to a normal disease that we have come to grow accustomed to, like a seasonal influenza, I think we all can live in back to a normal life again. So very, very important comment here that it does not prevent, it does not stop you from getting the infection, but it's converting a severe, potentially severe disease that requires 8% chance of hospitalization to now 0 for the few patients that we have in Singapore.
Yeah, I can add our experience in Italy the same like yours. We have some after vaccination we have a few cases of infection, but with very, very mild form, and they do not need hospitalization, which is very good to know, and showing that this is the efficacy of vaccine. Doesn't mean that you cannot have anymore the infection, but you will have very mild infection. We do not need hospitalization, and will avoid overloading of hospitals and healthcare.
Thank you, Professor Imatsuba. One question that is been asking people to ask is that the people who has been a little bit immunocompromised, like patient on hemodialysis or patient taking disease-modified drugs for rheumatoid arthritis or renal transplant, whether they need a 3rd dose of vaccine or not. And that question, I think, still remain unanswered, will be answered in future. And does the panelist, Professor Tan, do you want to comment on that?
I have to say that in all this group of patients that you mentioned, they are not contraindicated as far as COVID-19 vaccination goes in Singapore. We feel that patient renal transplant, end stage on dialysis, all these patients are suitable for vaccination. The only group of patients that we say right now, maybe you want to just hold on, will be those patients who have got cancer and currently undergoing immunosuppressive therapy. But once you complete your whole course of chemo, you are actually fit to go for your vaccination.
Professor Mirjamal, are you with us? Professor Mirjamal?
Yes, I'm with you.
Would you
yes, I'm with you. Thank you, IPDI, for arranging this time-requiring program. And we are grateful to you for arranging this. And in this session, I have enjoyed all the 3 lectures from Professor Imatsuba, Dr. Tan Hui Sim, and Dr. Arun Maski, the 3 stars of the world in the field of intervention. I do not want to take much time, but I want to know few things from Tan Hui Sim, that regarding the vaccine, we are in problem that we have given some people the AstraZeneca 1st dose, but due to the lack of the vaccine, we could not be able to give the 2nd dose of AstraZeneca, though it may come in the very soon. But whether we can give 2nd dose by Moderna or Pfizer vaccine, is there any problem of giving 2nd dose? This is my first question. And second question is there any need of booster those who have taken 2 AstraZeneca doses? I like to know these 2 things from Tan Hui Sim, though I know, as per my knowledge, that these points are yet to be determined, not yet to be decided, but I want to know from you, what is the decision?
My take here is that there are currently no answers to the 2 questions that you just asked me. Nobody knows whether mixing vaccines is going to be helpful and so forth. But I suspect I have to go for a 2nd Sinovac if I ever want to go to China. The whole thing has become so politicized. So you are forced by circumstances to take a 2nd type of vaccine just so that you can travel. But I would say that at this point in time, there's no evidence to say that you need to mix it up, or whether you will achieve the same sort of effect with 2 doses from a single vaccine. The second question is whether we need booster. I suspect this is going to be an endemic disease that we're going to live with. And so like a seasonal flu vaccine, so we will take it every year. So we take it every year in the hospital here, North Hemisphere as well as South Hemisphere, flu vaccine every 6 months. So So I suspect the future may be like that. But again, we are still looking at the science and evidence to before we can recommend this booster.
We have with us Professor Fazila Malik. I have a question.
Hello.
Professor Fazila Malik is the Chief Consultant and Professor, National Heart Foundation Hospital and Research Institute. My question is, what do you think of the vaccination of the elderly patients who have pre-existing ischemic heart disease? Is there any problem with that?
You're asking me the question. Well, thank you, Wadud. First of all, let me congratulate you and the other team members of IPDI for arranging such a wonderful and time-worthy conference. We're all really benefiting from it. And congratulations to all three speakers. We all know you always give great presentations, but these were really awesome. I learned such a lot from all three of you, as I always do. So thank you for sharing your experience and your knowledge with us. Having said that, about the elderly patients with coronary, I'm totally for vaccination. I truly believe that vaccination protects, and I think that, of course, we should be giving our elderly patients with coronary artery disease vaccines, and age should not be a bar. And another thing that you were saying about 3 doses for transplant patients or immunosuppressed patients, there was an anecdotal report in Medscape about a surgeon who had undergone transplant, and he first took 2 Pfizer vaccines, and the third was a Johnson & Johnson, and only after he had taken the third Johnson & Johnson single dose, his antibodies really shot up. So there was this question posed that maybe for immunosuppressed patients, you could give 2 doses and then go for a third dose with another vaccine. But obviously that is anecdotal. But thank you again for this wonderful conference.
Thank you, sir. Thank you, madam. Thank you for joining with us. I'm requesting Professor Khalid Mohsin, sir, for the last comments to this session. We are waiting for another exciting session, pre-paper session for the young investigators.
Thank you, Dr. Mohsin, and thank you, Professor Wadud Chaudhary. It's a really masterful presentation from all the 3 speakers. Actually, I have a few comments and queries to Dr. Arun Baski. We consider him as our homegrown cardiologist. Arun, what was the ACT of this patient during the coronary intervention, number 1? Number 2, did you screen the patient for a PFO? Because we know that the pulmonary embolism is very highly endemic in the COVID situation. Was the patient having a PFO? And number 3 is, what is your opinion about the safety of MRI immediately after implanting a stent in the coronary artery? Just I want to expect 3.
Yeah, thank you. ACT was more than 420 seconds. And this patient was on regular follow-up since last 12 years. So there was no PFO. And MRI, I think, is a safe procedure after post-PCI. And my hospital is a dedicated cardiac hospital. We have a CT scans. We do not have MRI. And during COVID pandemic, so we had great difficulty in shifting the patients. That took a lot of time. And consulting neurologists with a suspected COVID was an issue. I don't think there's any issue with the MRI in stent patients. It's quite safe.
Thank you. Thank you, sir. Hello. We move forward for the third session, session 3.